Hello everyone, I'm called Ronald. I'm a general surgeon, and today we shall go through the initial assessment of trauma. This is part of the Kampala Advanced Trauma Care Course series, and we recognize our partners in the Yale Department of Surgery, the UCSF Department of Surgery, the Laura Case Trust, Mulago Hospital, and the global partners in anesthesia and surgery for coming up with this information. So in today's lecture, we shall look at the epidemiology of trauma. We shall try to highlight the physiology of trauma and trauma patients, the strategies in management. We shall look at a few adaptations for resource-limited settings and discuss a case. So the goals of this tutorial discussion should be to discuss the strategies to identify potential life-threatening injuries, to integrate physical exam findings, the mechanism of injury, and the history in order to make patient care decisions, and to develop an understanding of the basic interventions within initial assessment of a trauma patient. Particularly specific techniques will be discussed in other series. So there are about 5 million deaths worldwide from trauma globally, and the burden of this mortality is increased by 30%, will be increased by 30% by the year 2030. In Uganda here, urban centers usually account for trauma, 25% of all deaths related to trauma. And most of these deaths are male. Most of the individuals are male, 79% of these. And most of the injuries are caused by road traffic crash, 46% of these. So what happens in the physiology? Usually we have a shock state happening, and shock is an abnormality in the circulatory system resulting in inadequate organ perfusion and tissue oxygenation. There are 4 types of shock that we know, the commonest being the hypovolemic shock that gives you hemorrhagic shock, and this can be accounted for because of blood loss. There's also what they call obstructive shock, usually the case that we see in chest trauma when we have obstruction to chest cardiac activity. There is neurogenic shock that we see usually in head trauma, and more particularly in spinal trauma when we have spinal shock. And then we have other types of shock that could be anaphylactic or cardiogenic. So in the initial assessment and management, what we usually capitalize on is the primary survey. So it's divided into the primary survey and the secondary survey. The primary survey essentially are the ABCDEs of management of trauma. So what happens before we go to the ABCDEs? We begin with preparation. Preparation has a pre-hospital phase and an in-hospital phase. The pre-hospital phase, for places with developed pre-hospital systems, there is coordination with the pre-hospital agency, or usually an EMS or ambulance service or personnel, who usually notify the people in the hospital to prepare better for this patient. Sometimes the patient may come with already instituted measures that are life-saving, especially if you have very well-trained pre-hospital EMS or paramedics in the field. In the in-hospital phase, usually there is more advanced planning for the trauma patient's arrival. Teams are constituted ideally, and there is always a team leader identified, and the team leader together with the group members will assign specific tasks to these individuals. Personal protective equipment is worn, equipment is gathered, IV fluids are readied, monitors and drugs to receive the patient in the hospital. So what happens in the primary survey? The primary survey, like I've said, we pay attention to the ABCDEs, where A is airway and cervical spine protection, B is breathing and ventilation, C is saturation and control of hemorrhage, D is disability and essentially assessment of the neurological status of the patient. And E is exposure without causing hypothermia. So what happens in the airway assessment? We usually want to maintain cervical spine immobilization in case there is cervical spine injury until we rule it out. The head should not always be hyperextended, hyperflexed, or rotated. There are maneuvers that can be used to ensure that this happens. For example, steadying the head with the examiner's hands, or using other equipment like a rigid neck collar and head blocks could help with steadying the cervical spine to prevent transection of the cervical spine. So if the patient is able to speak to you, it is very likely that the airway is not immediately threatened. If the patient cannot speak to you and has a GCS of less than 8, this patient will require intubation because they do not have control of their own airway. So in airway management, usually we have to open the airway to assess visually, and there are simple basic airway opening maneuvers like the chin lift and the jaw thrust that we can institute to open the airway while maintaining a cervical spine immobilization. Usually we don't want to perform the head tilt if we suspect cervical spine injury, so we stick to the jaw thrust that can help us open the airway without destabilizing the cervical spine. So what do we inspect the airway for? Foreign bodies, blood or vomitus, and these are things that could obstruct the airway, and any other anatomical structures that could obstruct the airway. For example, in patients with facial trauma, we could find bony prominences, we could find the tongue falling back and obstructing the airway. The airway usually requires constant re-evaluation because it could block at any one time during the assessment. If we cannot maintain an airway with simple maneuvers, then we may have to institute maneuvers as complex as intubation or surgically putting an airway and this takes priority over any other intervention because we need to keep the airway open all the time. So in breathing and ventilation, we usually assess the neck for distension of the jugular venous system. We usually assess the trachea. If it's deviated, that could be a clue that there is something pushing from the opposite side of the chest, and we assess the chest itself. We inspect, palpate, percuss, and auscultate the chest. We auscultate for absence or presence of breath sounds. We palpate the chest wall for hyperresonance or dullness that could point to pneumothoraces or hemothoraces. We also palpate for crepitus, and we look out or inspect for the increased work of breathing the chest, and this we could see if an individual has nasal flaring, retraction of the chest wall, and is using accessory muscles to breathe. Usually we want to identify an abnormal respiratory rate. It's either too low, below 8 breaths per minute, or too high, above 30 breaths per minute. We want to look out for signs and symptoms of a tension pneumothorax and deal with it immediately. If we have tracheal deviation, and if we have a patient with low blood pressures, distended neck veins, and a low blood pressure or hypotension, which could be demonstrating signs of obstructive shock. We also want to tease out any massive pneumothorax. Any deviation of the trachea could point to this, and features of obstructive shock as demonstrated by hypotension and low blood pressures could also be pointers to this. Open pneumothorax, this could be more obvious, and paradoxical movements of the chest wall could point to a flail chest segment. Always ensure that breathing and ventilation is very well done because it takes precedence over any other interventions, and small procedures such as insertion of a chest tube or a needle decompression for that matter be very life-saving. In saturation and control of hemorrhage, in the assessment, usually we want to assess the blood volume status. We start this assessment by looking at the level of consciousness of the patient. We look at the skin color, the condition, the temperature of the patient. We do a capillary refill time, and we also do distal pulses, and we want to look for strength of these distal pulses. Finally, we do a blood pressure, measure the blood pressure, and since we know the normal is a systole of above 90 and the diastole of above 60, then we can tell if they are low blood pressures and intervene accordingly. Some of the causes of hypotension could be hemorrhage, and the patient could be exsanguinating a lot of blood from a peripheral bleeding extremity. Always apply pressure to control external bleeding, and this may require the institution of a tourniquet. Now, for hemorrhage can be classified, and there are certain pointers that could help you classify the level of hemorrhage that you have. And there are 4 classes of hemorrhage essentially, from class 1 to class 4. And you will appreciate that in class 1 hemorrhage, the individual has lost about 750 ml, which constitutes about 15% of their total blood volume. Will have a pulse that may be normal, a blood pressure that may be normal, a respiratory rate that will be normal, and may be mildly anxious or even normal. Now, as you transcend to higher classes of hemorrhage, which correspond with even higher amounts of blood loss, the vital signs get deranged. For example, in class 4 hemorrhage, where you have lost close to 40% of your total blood volume, the pulse rate is high, the patient is significantly tachycardic, the blood pressure is decreased, the respiratory rate is high to try to compensate, and the patient may be lethargic or even comatose. Always identify hypovolemic shock. Have a high index of suspicion for internal bleeding, especially in cavities that can hold the loss of blood: the chest, the abdomen, the pelvis, the retroperitoneum, and bleeding from long bones. In case you think there is concern for internal bleeding, always consult a surgeon early. So for saturation and control of hemorrhage assessment, what you want to do in intervention, you want to establish IV or IO access. This is intravenous or intraosseous access, and begin resuscitation quickly, usually with warm isotonic crystalloid. We prefer normal saline or lactated ringers, and we tailor the response to the patient's response, the resuscitation to the patient's response. In adults, we usually want to assess response after we give up to 2 liters, especially if we think they have lost volume. Please be very careful and look out for resuscitation in isolated head injuries. Usually, we want to maintain a perfusing blood pressure of 90/60 millimeters of mercury. So tailor your resuscitation to the response as guided by the blood pressure and other clinical signs. In children, we give a bolus that usually consists of 20 ml per kilogram, and then we constantly reevaluate and see if they have an increased need for fluid resuscitation. In situations where you have up to class 4 hemorrhage, especially when you have a patient very unresponsive to initial crystalloid resuscitation, please consider a blood transfusion. This picture is of a combat application tourniquet and other tourniquets that can be applied when you have blood loss from extremities. Please be very careful with application of tourniquets. Always adjust them to allow for perfusion to occur, and always record your tourniquet time when you apply a tourniquet on the upper and the lower extremity. So in the assessment for disability, which is essentially neurological assessment, we want to do a rapid neurological evaluation. We quickly establish the level of consciousness using a Glasgow Coma scale. We do a pupillary exam and we look out for any focal or lateralizing signs and withdraw from pain. We want to assess movement in all extremities. So the GCS or the Glasgow Coma scale basically assesses the best of three components: the best eye opening, the best verbal response, and the best motor response. So the maximum possible score is 15 and the least possible score is 3. And for patients with head injury, for example, their head injury can be classified into mild, moderate, or severe head injury depending on the Glasgow Coma scale that they have. For a patient with a GCS between 3 and 8, they have a severe head injury. For GCS between 9 and 12, they have a moderate head injury. And for patients who have a Glasgow Coma scale above 12, they have a mild traumatic brain injury. So always look out for the posture that your patient exhibits. They could have abnormal flexion that points to a decorticate posture and abnormal extension that points to a decerebrate posture that you could use for calculating and doing your GCS. In exposure or the environment, when we want to expose the patient without causing hypothermia, ensure that you remove all clothing. Log roll the patient while maintaining spinal immobilization in line with the C-spine, and inspect the thoracic lumbar spine as well as the back and the flanks for any ecchymosis to rule out hemorrhage, and the buttocks for ecchymosis. The final exam in a log roll usually should be a rectal exam for high-riding prostates when you suspect prostate injury and the kind of stuff. And then always cover your patient with a blanket to keep them warm. After doing the ABCDE, always reevaluate the ABCDE to identify new priorities that are life-saving and institute immediate life-saving remedies. Always look at the airway. Is it still patent or not? Is the patient breathing? Are they oxygenating well? Are they ventilating? Saturation, are they responding to your initial resuscitation with fluids? Or is there concern for uncontrolled bleeding? Then in the neurological status, is there a change in the mental state? Are they better or are they worse? And what could be causing this? In the environment, always look out for any environmental concerns, usually hyper or hypothermia. So there are what they call adjuncts, or some maneuvers we could do to help achieve the ABCDEs. The adjuncts to airway and breathing concerns include an ABG. It could be able to point to acidotic states and metabolic alkalosis. We had end-tidal CO2 or capnography monitoring. And then we have a chest x-ray, which could tell you a lot of information regarding pneumothorax, hemothorax, and any other chest injuries. For saturation, we usually want to have a blood pressure and have a monitor that gives us a continuous blood pressure monitoring. We want to have an ECG, and the tracing on the ECG could give us a lot of information regarding the stand of the patient. We want to insert a urinary catheter so that we assess the adequacy of resuscitation depending on the urine output of the patient. We may want to insert a nasogastric tube so that we can decompress the GIT. And like I've said, a trauma series of radiographs, which is the chest, abdominal, or pelvic x-ray, to look out for pneumothorax, hemothorax, diaphragmatic rupture, rupture of hollow viscus, and pelvic fractures. As an adjunct to saturation in the abdominal exam, we usually do a focused assessment for sonography, trauma, ultrasound scan, or a diagnostic peritoneal lavage to help rule out abdominal hemoperitoneum. So these pictures demonstrate the windows that we look at in the first scan, and we have a subxiphoid window. Then we have a window in the right upper quadrant, a window in the left upper quadrant, and a suprapubic window. So after the primary survey, we do the secondary survey for the initial assessment. And the secondary survey usually entails a focused history and a head-to-toe analysis of the patient. In the secondary survey, we usually repeat the GCS, the Glasgow Coma Scale, and we continuously reassess our patient. Please do not begin the secondary survey until the primary survey has been completely sorted and the patient is well resuscitated. As you can decipher, this could go on until you have done surgery and sorted causes of hemorrhage. So in the secondary survey, we take a focused history, and this is what is summarized in the mnemonic as an ample history, where A stands for history of allergies, M stands for history of chronically routinely taken medications, P stands for past medical history, hospitalizations and surgeries, L stands for the last meal taken or the last menstrual period, because pregnancy sometimes can compound on trauma presentations among the ladies. And then E stands to events leading to the injury that could help you establish the mechanism of injury. Then we do a head-to-toe assessment. In the head and face, we palpate the skull and the soft tissues of the head, which is the scalp essentially. We want to look out for signs of skull fractures, lacerations and abrasions that could bleed significantly. And then we palpate the face, usually the forehead for any fractures, the periorbital ridge for fractures as well, the nose, maxilla and mandible for fractures of the facial bones. We evaluate the eyes, the ears, nose and mouth. We do a visual acuity for the eyes and visual movements. We check the pupils and examine for foreign bodies in the eyes as well as bleeding in the conjunctiva. We examine the ears using an otoscope. We want to look out for bleeding from the orifices of the ears as well as leakage of cerebrospinal fluid in these orifices. We examine the nose. We palpate for fractured parts of the nose and then examine for blood escape from the nares. We examine the mouth. We inspect the teeth for any lost teeth. This could be lodged in the airway and causing trouble, and we look for any other foreign bodies in the nose. In the assessment of the cervical spine, in the event that we have a trauma to the facial bones and head trauma, always assume that these patients have a non-stable cervical spine injury until proven otherwise, or until excluded by X-ray or other clinical assessment. Immobilize the neck until you're fully able to evaluate the spine. In assessing the neck, inspect the neck veins for distension, which could be a pointer to reduced venous return. Inspect the trachea for any deviations, and inspect the neck for any foreign bodies or penetrating injuries. Palpate the cervical spine for tenderness, any soft tissue or subcutaneous emphysema, and auscultate for carotid rouge. In the chest, inspect the chest for chest symmetry, palpate the clavicles, ribs, and anterior chest wall for crepitus, tenderness, subcutaneous emphysemas, and pain that could point for fractures. Auscultate the chest, percuss for hyperresonance that could point to pneumothorax. Percuss for dullness that could point for pneumothorax. Auscultate for breath sounds, for absence or presence of breath sounds, and then heart sounds. Sometimes you have muffled heart sounds when you have pericardial tamponade. A chest X-ray is an adjunct to both primary and secondary survey in assessment of the chest in trauma. For the abdomen, inspect the abdomen for distension, signs of penetration, any ecchymosis, palpate for guarding, tenderness, rebound tenderness, and rigidity or firmness, and auscultate for bowel sounds, the presence or absence of bowel sounds and their quality in pitch and frequency. The adjuncts for abdominal assessment in the secondary survey include the first scan. You do the first scan, a diagnostic peritoneal event, and nowadays the CT scan in case you want to tease out some diagnosis in abdominal trauma. From the musculoskeletal system, inspect for any obvious lacerations, contusions, deformities, inspect for ecchymosis over the iliac wings, the pubic area, and the scrotum in case you have a pelvic fracture, and then palpate the pelvis, gentle anterior anteroposterior pressure on the iliac spines or the iliac wings to palpate and look out for pelvic stability that could help you tease out pelvic fractures. Please do not do this more than once. Many times when you want to test for pelvic stability, do not do it more than once, otherwise you cause more bleeding in the pelvis. For the extremities, look out for distal pulses, look out for motor and sensory exams in these extremities, obtain x-rays of the long bones if there is tenderness on palpation, and suspect pelvic fracture in event that you have unequal leg length. Palpate the spine, along the spine, the thoracic and lumbar spine to look for any obvious deformities that could point to transections of the spine. X-rays are adjuncts to secondary survey in assessment of the musculoskeletal system. Always inspect the perineum, the rectum, and the vagina. We want to examine the perineum for any contusions, hematomas, lacerations, and urethral bleeding. That this could point to pelvic fractures and other concealed visceral structure injuries like urethral injuries. Blood at the urethromeatus or bruising of the perineum are contraindications to insertion of the Foley's catheter because you may have urethral injury and worsen this. We want to do a digital rectal exam so that we assess for presence of blood in the rectum, anal sphincter tone, as well as look at the prostate in males for a high riding prostate. We want to examine the vagina among ladies for presence of lacerations or blood in the vaginal vault, and always please endeavor to perform a pregnancy test on all females of childbearing age because the spectrum of trauma presentation could always change, confounded by the physiological changes that happen during pregnancy. Always perform a neurologic exam, a complete one, reassess or repeat the GCS. Look for the level of consciousness, assess the pupillary size and the response of these people, and then perform a motor and sensory evaluation of the extremities. In event that you have a suspicious limb that you may think may have a fracture, please immobilize this and always maintain your patient in full spine immobilization until spinal cord injuries have been ruled out by clinic exam or radiology. Now there are missed injuries and always struggle to minimize these. Maintain a very high index of suspicion. Provide continuous monitoring of the patient status, and then specialized diagnostic testing should be done to identify and include injuries that are routinely missed. Always seek an early surgical consult if you suspect surgically significant situations, and reevaluate your patient often, including other tertiary exams. A tertiary exam is a repeat of the secondary survey after 12 to 24 hours to avoid any injuries. So What adaptations are available for resource limited settings where you cannot get all the things that we have talked about? If you do not have a CT scan, use your clinical acumen to identify any pathology or use any other basic routinely available investigations like X-rays and abdominal scans or fast scan to tease out life-threatening injuries. If you do not have blood or blood products, give IV fluids and then conserve whatever it is you have by identifying and controlling hemorrhage early. If you do not have ICU or ventilators and you need to maintain a very good airway, consider early institution of a tracheostomy. Always consult with a specialist needed for the specific trauma early. So we have a case study here for discussion. And in our case study, we have a 44-year-old male driver of a car who crashed head-on into a wall. He was found unresponsive at the scene. He arrives at the hospital with a cervical collar in place and strapped to a backboard. His breathing is being assisted by a bag, valve, and mask device. What could be your initial steps in management? Please think about this and always rush back to the A, B, C, D, E's in that order. Identify life-threatening injuries in those systems and fix them immediately. So we prepared this presentation using useful resources as is demonstrated in the slide, an epidemiology overview, a trauma.org, trauma care manual, trauma management, and the advanced trauma and life support protocols. We recognize the participation of these collaborators who helped put this information together